All right, everybody, we are kicking off a brand new season because apparently most podcasts do seasons. And on year 7, we figured that out. So go team. But, we're cool. Chad, thank you. And I felt like kicking off a brand new season with one of the most respected and radiant colleagues that we have out there. So, y'all, I have the honor of having Casey Lewis on. And she is, as we were talking beforehand, we are both in our mama bear active modes, advocating for our tiny humans. Mine currently upstairs recovering from a concussion because a child whacked him in the face with a tree branch when nobody was watching. We're fine. It's fine. And hers for her own reason. But y'all, mama bear life, it is not for the faint of heart. And that's okay. So here is your trauma-informed warning. We are going to talk about the NICU, and both of us are NICU mommies. Hers much more complex than mine. And if you're pregnant or if you've had a baby in the NICU, this could potentially be triggering. But we are going to choose joy, and we are going to give the message that needs to be delivered. And we appreciate you walking with us. So, Casey, dear God woman, it's been a minute. Hi.
Hi, it has. It's been too long. Time passes by and I can't keep up half the time, especially now as a mom.
Yeah. And I slept last night because sleep regression at 10 is a real thing when your husband has the bright idea to let your 10-year-old watch it for Halloween.
Oh wow. Yeah. Mm-hmm.
Yep. Mm-hmm.
Okay.
Mm-hmm. That is not a mom fail. I wasn't here for that. That's a dad fail.
Right. I hear you.
Okay, so folks, I'm going to go through Casey's delightful alphabet soup, and then I'm going to have her translate what some of these mean because some of them I know, some of them supersede my skill set, and we want the backstory, love. So it's Casey Lewis, MS, CCC-SLP, BCS-S, CNT, CLC, NTMTC, and I feel like that should be a rap song.
It should be. So you sound good saying that, but that's neonatal touch and massage therapist certified. Yes.
So you know how to rub the babies to bring comfort, joy, and healing.
Yes. And it really taught me a lot about just like trauma informed care. And I started that journey. I don't know, that was early on in my NICU career. So it gave me a more holistic mindset rather than kind of standardized care, which I didn't want to have. So I'm really glad I took that course and maintained that certification.
Nice.
Yes.
Okay. So we know you as NICU SLP and now NICU Mama, but what took you, of all of the aspects within our field and then our field in general, what brought you here? Take us to the beginning.
Yeah, wow. That feels like, almost a different version of me. I think it probably was a different version of me. I don't know. I always wanted to be in the NICU. I think you hear that a lot as in the SLP world or even OT and PT world. And, as you know, it's extremely hard to get into. And I understand that at times. And I also don't understand that at times. I understand protecting this space, but sometimes I do think that we need to provide more opportunities for therapists to train in the setting. But I did a placement in grad school at our children's house at Baylor in Dallas, which I don't believe operates anymore. But it taught me a lot just about, feeding therapy. I think at that time, feeding therapy was not what it is now. There was no pediatric feeding disorder. And so I felt like I saw cracks of the system back then and just opportunities to change things. But really what I wanted to do was to change things from the beginning. And that, looking back, that probably stems back from, my brother has autism and he's nonverbal. And I remember him speaking to me as a child. And I'm the youngest of 4, so he's the third in line. And I would always think, when I was 6 or 7, I wish I could go back in time and give him the support he needed. And that probably, looking back, that's probably where that relationship came from. I kind of just made that connection while speaking out loud. Isn't that kind of funny?
Here, this is that safe space.
Yeah. And I started my career in the nursing homes. It's not the NICU. Yeah. Started my career in the nursing homes. It taught me a lot about the need to advocate and how to have, compassion for others. I was at the end of life most of my time. It was a very hard time for me. I stayed in that setting, I think, 3.5 years. But I learned how to stand up for myself, which I think, as a NICU clinician, you have to know how to do that. And I think any clinician, and I don't mean that in an abrasive and aggressive way, but you have to have a sense of confidence to yourself, or how are people going to hear you? You don't have to be loud. I don't believe in that. I do believe you need to be clear. Being clear is kind, and that's what Brene Brown says, and I try to live by that. Anyway, so then I did adult home health on the side to make more money because I was a new grad. And then I did 1 year in the public school system. I needed to move home to be closer to my family at the time. I learned a lot in that year. It was such a happy year for me. I loved, it was the life skills class that I was mostly with. And
I love that.
Yeah. And that was special for me because I also felt like I was giving back to my brother, and I always wanted to work with children with autism. And then I learned, that's really not my thing. I want to do something else. I think probably it was too triggering for me emotionally. And then I got a job splitting my time in the adult acute care, adult ICU, and NICU in a community-based hospital, which I've learned now that is kind of like what I love, is community-based care. And then I had to advocate to be full-time NICU. And then while I was full-time NICU, I decided I'm going to start my own business. And I was doing both for a while, which was really challenging, especially during the pandemic. And then I went full-time NICU, became a NICU mom, and here I am.
That's so what I find is that those of us that, how do I say this nicely? We don't fit well into boxes, myself included in this. There's key words when we look back on our professional journey. Advocate. Earlier you talked about being a visionary, because you are, ma'am. The ability to speak power into a space that needs to hear it. And alongside of that, it's us growing personally as well as professionally to find where we are meant to serve and be and create and affect change, right? Also, honey, I spent 6 weeks in a nursing home. I was there 2 weeks, gave my 4-week notice, and then resigned because I just wanted to hug all the old people because my grandma raised me. And professionally, you cannot hug all of the old people.
I bet they loved you.
They did. But I was a terrible adult therapist because, again, everybody was my grandma, even though they weren't my grandma. And I was like, oh, hell's bells. This is not going to work.
No. And it's hard when they move on too. That's when it's really hard. But thank you for offering your time in that space for a little while.
Good. We were there. But I don't know. There's something about our world professionally where I see layers of mean girl clubs where there's gatekeeping. You have to start here. You have to be here. You have to fit in this space. But y'all, I'm going to be I like how the camera's here, but the microphone is off-site. It's actually, to be completely honest, every setting is as equally challenging as another if we just acknowledge it. Working in the schools is no less difficult or complicated than working in a level 4 trauma because they have barriers in both. There's access to care limitations. There's insufficient equity in those that we are called to serve, as well as within our own profession. So given the world climate and the train wreck that it is right now, May we please choose kindness and patience with one another. And there's a very, very big soapbox, and I'll pretend that's the only one I have today. But you and I both know that there's more soapboxes, and I'm sure we all have them as well. So on that note, I am going to transition to Casey's lovely questions that she gave. So when we're talking about being in the NICU, there's different skills and different traits to help one not only survive in that space, but grow, thrive, and thrive. So help us. What would you recommend, love?
Yeah, I think if you can get in tune with your listening skills and learn to listen, that was something I had to learn. And I still try to, even probably apply to my own personal life, is just learn to listen before you speak. And, see, I also feel like that my intuition's very strong, and I've always led with my gut. And that's played well for me in my career in the NICU. And then also being quick on your feet, because you're going to have dynamics between your therapy team, your leadership team, the neonatologists, the nurse practitioners, and then also the bedside nurses. And to be honest with you, it is a lot to navigate. And anytime I was just overwhelmed by it, I would, maybe step out of the NICU or try to put in for a day off. Because I think about it a lot, and, the space, as much as I love it, can be extremely overwhelming. And, now I might feel that even more so now that I've experienced it, from the human aspect of being a mother. There's just so much trauma in the space. And I can even remember being, full-time bedside NICU clinician in the space and becoming extremely disassociated to what I was doing.
Wait, translate. There's so much to unpack in what you just said. Okay.
But, I could remember being in throughout my day doing cares with a baby, in an isolate or an incubator, and you're talking about lunch, what you're going to get for lunch, or what you're going to do over the weekend with the bedside nurse, rather than being in tune with the baby's needs in that moment. It's easy to forget the baby is a human. I don't know how to explain it. It can feel like the baby is it's just, I don't know. You just become so disassociated to what's going on around you, because it is your day-to-day life. And this is how you, I don't know.
You're surviving. You're surviving. I did, I started out in the public schools while I was getting my master's degree. And then I went to an adult hospital, ICU, med-surg adult in the morning. And in the afternoon, I was literally the only clinician for 40 miles in all directions, because it was a super rural area of Virginia. And I saw from 2 to end of life care. But my emotions in the ICU, when I got called in and it was, are we doing palliative or are we doing hospice? There would be times I would go in and I was going through the actions and present, but it was like my hamster ball shield was up too thick, because it was a lot of death. It was lots of 80, 90-year-olds in that setting that, they would, all right, well, let's send Michelle in, because I was a speech department of one. And it was basically, we just want Michelle to call them NPO or offer a tube. And it was just there's, what are we doing here? But also valid, complex cancers and stage Alzheimer's dementia. So I get it, but you're guarding your heart so that you hopefully don't take it home with you.
Yeah. Oh, I mean, I love the space so much. I think being a mother now, I see there's just so much more opportunity for improvement. I could remember, sitting there and the bedside nurses are laughing so loud, at the nurse's station, and and it's like my baby's trying to sleep. I would get very frustrated by that, but I'm like, well, I'm not going to say anything. It's like, I don't have that energy in me right now. I want everyone to like my baby, like everyone be nice to my baby. Don't have the mom that's going to complain, because she knows better. Or she knows, the evidence, because, people that work with me know that I know the literature very well and I'm up to date on my practice. But I just remember that as a mom, it was extremely frustrating. Like, the NICU is a healing space, but the people that work in the space are humans, and they go home to their families and they leave. And it's like, I feel like there's just so much. Sometimes I think healthcare providers that's just my space, any provider, we should like have monthly counseling sessions that's paid for by our employer to digest what we're going through, and even like process the reality of it all. I don't know. It's very complex and to think about, as a clinician and then also a mom. But the ICU is not, a fun place to be. It's a dream workplace for a lot of people. But the people that are there to get the help, that is not where they want to be.
No. Mm-hmm. No. I did it for a skinny minute as a mom because Bear was a 35-weeker, and we had labor stopped 14 times to get him to week 35. And then he came out at 35 weeks, 6 pounds, 12 ounces. I grow huge babies. He was
a big baby.
He was a big baby, the fattest baby in the NICU. Mm-hmm. And there he was around all of these little ones that were smaller than my hand. And there's my giant man cub of a child. And I'm like, I could never do this. But it was terrifying seeing him in there just for the brief period that we were in there. So I can't fathom the duality of knowing what you know and then having your own baby girl who is adorable. Cheeks for days. Love this. Walking in and her being there. But when you talked about active listening, and that's something that I feel like there are inherent barriers, wearing former clinic director hat, of placing clinicians in those settings to get the opportunities to learn what it's like to be a NICU SLP, because there's so few NICUs, there's so few NICU SLPs, and it's a highly competitive site, right? But
very political. I mean, I think just to say that and recognize that, and I recognize that, like we don't need to be, not that you are, I'm just saying in general, I feel like it's kind of secretive that, it is political.
Yes. Yeah. Honey, I worked at 2 separate universities, and one of them, not an HBCU, but a predominantly minority university. And it was very difficult to advocate for our students because NICU clinicians wanted the students from the PWI, the predominantly white institute that was also in the state. But it is what it is. I'm raising awareness about it. Know better, do better. But how do we teach that or cultivate those active listening skills when it comes to listening to the caregivers, especially those that come from different backgrounds that may not look like the treating clinician?
Well, it's a systemic problem because the therapists have productivity standards,
Even in the NICU? That's naive of me, but seriously?
Yeah, even in the NICU. I would say it's, I don't know if it's as strict, but I mean, they're checking your units build every day. And so I would feel like, I look back, I think it's kind of hard for me to remember, to be honest, but as a new clinician there, I was very overstimulated by knowing, okay, this is what I need to know for my knowledge base. This is how many units I need to meet a day before my boss doesn't stare at my units build anymore and leaves me alone. Then this is how I need to take a deep breath and learn how to communicate with a family that's, grieving and going through a traumatic situation. So it's a lot to process. I hope that made sense.
Yes. We had I think one of the best things that ever happened, because I was a speech department of one, I got grace. It was, if there was patients, there was all of them. I had to see all of them. If there were no patients, because rural setting when I worked at the hospital, there was nobody to see, right? So it was what it was. So I had inherent grace in the productivity standards during my CF in my first year as like a seed therapist. But um, the one of the best things that Sean, who is our boss, everybody called him Boss Man, ever did for us was he had everybody on the team um, truly focus on facilitating those conversations and rural community care. Right, we didn't have the productivity measurements that other settings do. And hell, we didn't even have a NICU. Everybody got flown in a helicopter over to the big hospital for that. Um, but crucial conversations, that was a really good resource. Dare to Lead by Brene Brown has been, that book has been profound on me. There's other books and resources that made me as a clinician want to shut up and just have the sit in the awkward pause. Dr. Frances Burns, one of my mentors, she was great at asking the question and then using her whole body language to physically pull the answer out of people. It was like magic. Watching her do this is like, some people are really freaking good at that. She's one of them. But
you are one of those people.
Oh. Well, thank you. But like, what was there anything that you were like, okay, this, I can take away this nugget of information and make it better?
Mm-hmm. I don't know. There's more than one. I think it's not even in therapy space. It's like in the provider space, like in how the doctors care for the families. I would say most of the time, the therapists are doing all that they can, given that the boundaries that's been imposed by them by the healthcare system. And I would say the same for the nurses. And I have immense respect for the doctors. I know that they have limitations placed on them that I do not fully understand because I'm not in their shoes. But they don't get enough time to spend with the family. If when I did have a doctor come to the bedside, they were there for 30 seconds. And it was like, oh, I'm going to listen to your baby. I'm like, okay, well, what else are you going to do? And so it just kind of, and by the way, that bill for the physician's bill was the highest bill out of all the bills that came from the NICU. And so, yeah, I understand they might be looking at the chart, and they are looking at her chart and looking at, her weight gain and, those things like that. But it didn't feel intimate. It felt very robotic and standardized and lackluster. I was so unimpressed. And I don't mean that disrespectful to our colleagues, because I understand that there's limitations placed on them that I do not understand. But they aren't. With that being said, they aren't able to do the job that they probably signed up for.
Yeah,
because they have these immense productivity standards that, again, I don't understand, but I can understand as a therapist. And going back to the productivity standards as a therapist, if you're not meeting that, they could pull you out of the NICU if you're a community-based hospital and be like, you're not meeting this, you're not demonstrating your need for this space, we're going to put you in the adult space. Like, you're being moved because you're not meeting productivity standards. And so it's always a fight to be like, I've got to prove my worth, I've got to make my value known here, because a lot of, I will just speak for for-profit hospital systems, view the employment of a therapist as, you're not getting profit from them.
Okay. So then that leads to, how do we improve advocacy?
Yeah, it's, I don't know, do we advocate to insurance companies? I don't know how that works on that large scale. But
I don't know, but I have to fix my hair because now I'm pissed for you. And I'm like, I need to stim on something, so here goes my hair down.
I know, but if people could understand, just because I'm also an adult therapist, I have that understanding too, and I have a business. And so that the role of the therapist, if we could just try to understand from a financial perspective, is actually to decrease the length of stay. That is a financial gain for the hospital system, for the system itself. And so I hear people on the face, I'm on Facebook, in Facebook groups, and there's chats going on, and they're like, we're being told that our services aren't needed, or that we're being told that parents are being billed separately for our services, when really it's all a bundle payment system. And really the people that are being billed like separately for the services are the providers. And sometimes providers are threatening that misconception or misinformation, because some providers don't want therapists in the space because we are trying to implement safe practices that kind of contradict what they want and what they think. For instance, like feeding on different levels of respiratory support. Maybe the therapist is saying that's not safe, and then the provider is saying it is safe, and then there's just a big clash and big disagreement. And then they think if we just feed this baby that, they'll get out quicker. You know what? A lot of times, I don't want to say a lot. Sometimes they do. I disagree that a lot of times they do. But what happens is they're readmitted to a children's hospital in a week or 2 weeks with pneumonia.
Yes. 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 Or they wanting to introduce PO trials too early.
Mm-hmm. Yes.
Y'all, 34 weeks at the earliest. And this is because the enteric nervous system, the nervous system of the GI tract, may not be fully developed, so that if you get it into the oral cavity, it could get stuck in the esophagus because the lower esophageal sphincter might not be hardwired to actually allow a bolus to go through. And where's it going to go when you go to put a baby down? It's going to go back up for inhalation, which is how we kill things. So there's that. There's my.
It's just hard because you can know all of this knowledge, now that I feel like I have, the empathy now of being a mother in the space. So It's just like, I love the space even more and more sensitive to it. I'm very sensitive to the space, let's be honest, but, I don't understand. It's like, you can know all of the research and know what's right, but then you're fighting against the system, like a for-profit system. And so, and not all systems are for profit. Some are not for profit, but it's just, you've got to figure out how to, talk that language and figure out a way to make your need in that space known if you're getting challenged in that way. And, if you are decreasing length of stay, which I do believe you are as a therapist, and I believe that wholeheartedly, come up with a QI project that demonstrates that, so you have data to support you.
QI project.
Mm-hmm. Quality, or like an improvement project, a quality improvement project. And so like maybe you're doing or even if it's not, if that's a little too complex, you can start with parent satisfaction. Like, were you satisfied? Like, how did you feel after I gave your baby a massage today? Or how did you feel after I helped your baby go skin to skin? Because a lot of what we do in the hospital system is they want parents to be satisfied, right? They want the parents to talk about them in the community, that this is the best hospital to come to. And so that makes them really happy, the hospital leadership, from a financial standpoint, because that's marketing out in the community. But try not to get bogged down in that. Try to disconnect yourself from that, because it can make what you're doing feel not authentic. But I'm just trying to help come up with ways to improve care and improve leadership's understanding of why you're needed to be in there. I'm just saying that because a lot of therapists are pulled from the space when they are not, quote unquote, demonstrating value.
So, couple of thoughts. We have guidelines for standards of care that are best practice culminated by ASHA, right? And folks, I have my C's. I'm proud of my C's. I will keep my C's. Is ASHA perfect? Nope. Is any entity perfect? Nope. But you know what? I have been blessed because of hats that I've worn, programs that I've been through, to see the advocacy and change be done on a national level, so that our national associations can partner with our state associations. Your state association should have a lobbyist. Not all state associations do, because they're so small, they literally can't afford a lobbyist, right? But your lobbyist can network with other interprofessional practice partners, lobbying associations. Do you know Kelly Caldwell from South Carolina? Kelly Kelly makes advocacy look easy because she's so freaking good at her job. And her job, which is technically adult voice, but her volunteer work with Skisha, right? She has been able to pull in the South Carolina lobbyists to partner with the OT Association lobbyists, the PT Association lobbyists to drive change in the early intervention setting, to drive systemic change. But your hospitalists have, there's associations for the American Academy of Pediatrics. They have a state chapter. If there is a large enough issue, my question to everybody listening is, have you voiced this to your state association? Have you joined your state association because you are your state association so that you can put, as my dad would say, teeth in your tiger? Normally in our family, we pray that we take the teeth out of our tiger when we're in a fight, but sometimes you need them back in there. But y'all, they can help lobby and advocate at a much higher level if your hands are tied in-house. And they just need to be told what's going on. Because
I would say that, as you know, feeding in the NICU is, in terms of who is doing it. Is it going to be the speech pathologist? Is it going to be the occupational therapist? Is it going to be the physical therapist? Mm-hmm. I feel like the guidelines out by ASHA for scope of practice can be a little bit more direct. And there's opportunity there. There's opportunity within my own state. And this is not, me trying to claim ownership over the space or anything, but what it does is create confusion. If you think about it from a hospital leadership standpoint, who's going to do this, who's going to do this, and who's going to do this? The NICU is confusing because we all have a therapy mindset. We all generally try to be holistic in our care. And that's just who we are as therapists. That's just, if you're a therapist, that's, you share that commonality. But that's what I wish, because I do expert witnessing now. I'm thinking, like, from a legal standpoint, who's supposed to be doing this? Who's supposed to be doing this? And who's supposed to be doing this? Because there also can create friction between our colleagues. Who's going to own the feeding space? Mm-hmm.
Yeah. If there's clear-cut guidelines, so then maybe that's where we could start as a profession, is advocating for more distinct, clear-cut guidelines and scope of practices. And then,
from my understanding, AOTA has a distinct statement, and I could be extremely wrong, and so don't quote me on this, but they have, like, more concise statements about dysphagia, I feel like, than ASHA might, or my state in Texas might, about the scope of practice of a speech pathologist in the dysphagia space in the NICU or the swallowing space. And so that's just another room for advocacy. And that's just also from a protection standpoint. That's how I view it now, because I've learned a lot being an expert witness, is that when things are gray and fuzzy, it makes things confusing for everyone.
Yep. Squirrel. So, oh God, how many years ago? Bear was little. So probably like 8 years ago, maybe 7 years ago, the music therapist tried to set up a practice act in South Carolina so that they could have licensure. They wanted licensure to bill under essentially the CPT codes associated, predominantly used by speech. Well, speech pathologists, we don't own our CPT codes. 92507 treatment for language, 92526 treatment for dysphagia feeding, or the eval codes. The AMA owns all of the CPT codes, right? So, which is kind of crazy, but anywho, they do, right? So when they went to pitch to the senators that they could do, that they should have a license, bless them, they literally copy pasted the Speech Pathology Licensure Act and said they could do everything that we could, including but not limited to dysphagia and treatment of traumatic brain injury. It was literally copy paste. and it was our lobbyist and our state association. We had to go and like testify and stand up and protect our rights and blah, 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 blah. But I witnessed and saw how a licensure act can be changed, can be updated, can be improved. So what Casey's talking about, y'all, it can be done. But then it goes back into the political realm of big government. I mean, we had a senator one time in South Carolina tried to say nobody needed CEUs. He tried to pitch that all physicians and allied health therapists no longer required continuing education. Why you would want your doctors or your allied health team members not to take another continuing ed course? I mean, that got squashed. Like all of the associations got wind of the proposed act and or proposed legislation, and within 48 hours, it was like creamed, annihilated out of there. But scary things can happen. So advocate with grace. But that was a big squirrel. Big things happen. Okay. So I know this isn't in what we were planning to talk about, but what do you do as an expert witness? Can you talk about that? Because that's kind of really, really cool and terrifying at the same time.
Yeah. So while I was pregnant, I was approached by an attorney in a different state, which was really shocking to me at the time because I was like, what's going on here? Called me, told me the story, said, would you be interested? And I said, okay, send it, let me review it. But, I would, what I do currently with it, I'm offering my expertise in the space of dysphagia and swallowing. And I'm doing it across a lifespan. So it could be for a baby that unfortunately passed away, that had dysphagia and swallowing difficulties, or it could be for an adult in the ICU. Unfortunately, all of these people are generally passing away. And so they need an expert to come in that's not associated with, the situation at hand to provide, non-biased information about what happened and what could have or should have been done differently to prevent someone's death, unfortunately. But, I think we know as just humans that not everyone receives excellent care all of the time. And I would say most people don't.
Mm-hmm. So that means we should make sure that we're accurately documenting everything that happens.
Oh, for sure. That's why and have liability insurance. Don't just have your employer's insurance. You're always protecting yourself first. And so that, I know it's and it's some kind of investment to have that every year, but it's important to protect yourself and your family. Not that none of us would purposely do anything wrong. But life happens, and maybe you're going to misdocument on something, because you're probably trying to meet your productivity standards, and life happens. But you always need to protect yourself first.
I've had mine for so long that I now get a discount for Nerd Factor because I have so many CEUs and time that I've kept it, because I've had the same liability insurance since I was like a grad student. And I'm like, I'm not a senior citizen, but when they gave me a discount for having that long, I was like, oh, I feel like this is the middle age discount.
I've got that. I'm jealous.
I was like, sweet. It happened about the same time my kid sister, who's only like 2.5 years younger than me, was told she was having a geriatric pregnancy. And I was like, oh, yay, we're both old.
Oh my gosh. That's not old, by the way.
I know. But, huzzah for 41, baby. Wait, how old will I be when this airs? Huzzah for 42. I don't know how the hell that happened. I swear I was in my punk rock grunge Doc Martin stage. Just Doc Martin now has a beautiful persimmon red shoe velvet that I think needs to be my birthday present to myself. Yeah,
Do
we're
it.
fine.
Yeah.
Do it. Yeah. Life's too short. Buy the velvet ducks.
That's
Okay.
right.
So one of the areas that often gets overlooked in neonatal care is the follow-up for grads when they leave. I can tell you, I never heard back from anybody in the NICU after Bear was born. Um, oh, yeah, no, didn't. But what explain what you see, what you've experienced, and how we can improve that.
I mean, I want to be gentle with my words, but my strife and is there's frustration with the physicians that follow up on this. And again, I understand that they're whatever, they have their limitations, but I don't know. I just felt like I did not have a good. They didn't understand, prematurity, and maybe that's because I went to 3 different physicians, and so it wasn't like I just picked one. I was like, I'm going to stick with you, and ultimately I did do that.
Wait, what do you mean? You toured the pediatricians before?
No, I took my daughter, and I was like, I don't feel right about this one. This
Good.
doesn't feel right. And I kind of got tired of that. I was like, I just have to pick one at this point. But they don't generally, and I want to be cautious with my words because making a they statement is dangerous. But generally speaking, what I've experienced is there's so much lack of understanding with feeding. I think we all know that, right, as clinicians. But to feel it as a mom is we're going off a piece of paper from the state of Texas that these are the milestones you need to meet, and this is what's read to me and given to me. And it's like, okay, here we go. Good job. On to the next. And so, the fortifying the milk to add extra calories, that was all on my own. I remember when we started talking about solids and how they said to introduce solids, and I would shake my head and nod, okay, but, you have to read this, but it was not correct. It's like, I worry about what the information other parents are getting because, I have someone that's very close to me in my life that really believes everything a doctor tells that person. And I'm on the exact opposite. I'm so questionable of everything in my life, and especially with providers, given my own clinical experience and my experience as a mom. And so I don't know, it would be ideal to have, I don't know how this would ever happen, but a feeding therapist in the pediatrician office, that would be ideal to me. And maybe that does exist, and it doesn't exist where I am. Maybe it's a cash pay pediatrician, but that's something I think we need. We need more lactation counselors or IBCLCs in pediatrician offices.
Yes, we do.
That understand what infant-guided feeding means. It's not just here, put the baby on the breast, and we're going to eat now. And I had that experience with a lactation consultant at one pediatrician office, and I was like, you do not understand prematurity and do not understand what infant-guided care means. And so I had, I was dealing with the C-section healing, I was dealing with my own hormones, and then also just the frustration in the healthcare system as well. And that's kind of, my goal is to use all of that for good and to try to make change. It would be great if I could advocate on a state level or a national level. That sounds fun, but you've got to have people with you that are going to do it with you, because I couldn't do that alone.
Yes. So all right. I left Columbia and had really great partnerships with local pediatricians. It was when the ICD-10 code was coming out, but it was, you go in, you do your eval, the ICD-10 code for PFD, chronic versus acute. And going from having had those great relationships and partnerships when I said, hey, I really think we need to consult with the specialist, or this infant's presenting with signs and symptoms of laryngomalacia, trachomalacia, bronchomalacia. It's not for me to decide what it is. I'm just telling you what I'm seeing, what I'm hearing, increased work of breathing, stridor. We need referral to ENT, blah, 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 blah. There was understanding and partnerships and relationships built in trust that take time to build. And I get, right? To go from that to Virginia, where I work in a valley, very, very rural setting. And essentially through the valley, there's only one other practice about 45 minutes away, straight as a crow flies. So it's longer than that. And another practice, but they don't really, one does some feeding, the other one kind of, sort of, right? So in walks me, and I'm like, we need to see all the specialists. You win a registered dietitian consult. You win ENT. Oh my God, you have head to toe eczema. You win allergy, right? So it's even at babies 4 months old, NICU grads can come in with eczema, and we're like, oh, what color is your stool? And they tell you it's green and sometimes pink. And how many formulas have you been on? I'm like, this is laying the framework for our milk protein allergies, right? Like this is the all of the symptoms are there. It has been challenging to create partnerships and trust with some of the local pediatricians who don't aren't familiar with the term pediatric feeding disorder, where they've been practicing for a while, probably never had this taught to them in school, and in walks a new to them therapist, and it's like, who is this woman, right? So y'all, the professional rage that I have felt in my soul for like a while with on behalf of some patients, it's a righteous anger. But what we did is we're partnering with different colleagues to create a free CEU event. And I am hoping that this will be all locked down and it's going live if this goes out the beginning of April in 4 weeks. Um, uh, to even have free CEUs from the Pediatricians Association, so that we're creating an opportunity for knowledge content. We're removing a financial barrier. If it's got the SIME stamp of approval, SHAV is green lighted at the Speech Hearing Association of Virginia, so we have approval there. And we get approval from the other, that creates an opportunity for learning, and not just from the speech therapist, but my girlfriend Tessa, who's a pediatrician. So I say all this because out of the anger and the frustration on behalf of the patients, and we're working at the one-to-one relationship with the special, like with them here, is how do we work the issue top down as well, right? And knowledge is powerful, but y'all, we're talking about a diagnostic code that's still only 2 years out, that a lot of people for regional variations are not familiar with. And infant feeding still falls on the umbrella of PFD, whether it be acute or chronic. Another opportunity, Feeding Matters has been advocating to get the screening tool embedded in with the ASQs, so that pediatricians, when they're doing those, like, this is the norms, that they're given that 6-question survey. So there's like but that's reliant on state associations or volunteers within the various states to advocate with the pediatricians to actually get it in their hands. And all of this is volunteer work, and most of us need a job.
So, yeah, I mean, that's impossible. I mean, to do all these things, and you have to have money to exist in this world, you know?
Yeah.
And so, I mean, I appreciate you doing all that.
I always tell my husband when he panics, I'm like, remember, they print money on Tuesday. And I've been saying that for years, but like now I'm a little worried that like we might not have paper money and I'm going to have to come up with a new line. Sorry. Yeah. But volunteer. So thoughts, what are your thoughts? What are actually,
I think I'm just sitting here as a mother, I think that I do my best to mesh the two worlds of being a clinician and a mother. And I don't know a pediatrician in my area. And, just because I don't know doesn't mean they don't exist. That knows what pediatric feeding disorder is or means. I don't even think that wasn't, part of our conversations with my daughter, who's a premature child. And so it's very interesting. But what I did when I was full-time in the NICU is I did my best to utilize that diagnosis when I was speaking to providers and in my presentations, because the goal of all of it, being a NICU therapist, is to reduce the incidence of, things like pediatric feeding disorder and also
Yep.
the stress on the healthcare system, right? You're trying to minimize all of those things. And so again, that's another way to speak the language from a financial and leadership standpoint, that you're trying, this is why you're important in the NICU, besides the ways I already know. But just that's another bullet point to add in your presentation.
Yeah. But actually doing presentations to that sphere, it's wild to me, and I don't know if this is ingrained in us. Where does this come from? I don't know. But I've never had an SLP actively encourage the next generation to start doing outreach to other associations, to other conferences. But let me rephrase that better. I feel like we are taught and ingrained from graduate school and maybe undergraduate that we should rely on our literature, hit the books, but the books that's often referred to are speech pathology dominant journals, speech pathology dominant books, right? But if we're engaging in interprofessional practice for optimal outcomes, we have to get out of our literature to learn about the other professions. But then I feel like we need to be encouraging ourselves and our colleagues to give back and start putting in call for papers at those conferences so that it goes both ways. Does that make sense?
Yeah, of course. It makes sense for sure.
There's a tiny bear cub post-concussion tiptoeing over to go grab his brother's Rubik's Cube. And yes,
It's important to have.
Rubik's Cubes change life. Get that loud Rubik's Cube upstairs. Thank you, sir. Sorry.
I hope it's okay.
We're color's good. I'm going to count it as a win. But yeah. But okay. So if you're a mom and you're in the NICU, and if you overlap and you're a NICU SLP mommy, or you want to become a NICU SLP, but you happen to, what life lessons can you give them? That's a hard question.
I think it's just really trying to, understand what trauma-informed care really means. I don't think I really understood it until I had, this trauma happen to me in my own life. Because that's life teaches you lessons. You don't know what you don't know, and you can't force understanding on yourself. And I don't want people to go through that, bad or traumatic things. That's how they learn. That's, I don't wish that for people. But just remember, the NICU is not where a mom wants to be. It's literally not where the mom wants to be. And there are times when I remember being a clinician and the mom wouldn't come very much, or the dad wouldn't come very much, or whatever that family dynamic looked like. And probably because they were navigating their own trauma and maybe, depression, and they didn't want to get out of bed. And then there's also moms like myself on the other end of the spectrum was well, I'm not leaving my baby. I'm going to be there every second of the day, and to the point where people were telling me to go home, which that also offended me. Because I'm what do you think? This is where I'm supposed to be. I will be here as much as I want to be here. And if I'll sleep in this chair, I'll sleep in this chair. Don't worry. I shower every day. I'll go home and shower. But also,
I definitely missed a few of those when the boys were little.
I don't even know. I remember there was not time in the day to shower. I remember that, but I did do that.
Yeah.
I don't know. I remember being frustrated by that statement. So there's judgment, subconscious, I think at times, you're where's this parent? Why aren't they here? And then why won't this parent leave? It's well, what do you want them to do? We're nothing's appeasing you. And so I don't know. I've experienced that a lot as a clinician, people talking about other families. I also have heard people talking about other families while I was sitting there as a mom, staff, and gossiping about them at the bedside. And I'm like, well, I guess I'll just play deaf and focus on my baby because I'm here for my baby. Like I can't get into other
That's not
people's
okay.
problems. I'm not here at work right now. But yeah, like think about what you're saying when you're in the NICU. If you need to talk like that, if you have that desire, go do it in the break room. Watch your words because words are extremely sensitive and heightened when you're going through something traumatic.
I saw a glimmer. It's the opposite of a trigger. I was trying to pull the analogy. And the glimmer said, words have power, speak healing over yourself. And I am self-deprecating humor is my default, right? Because especially if somebody gives me a compliment, I struggle with receiving words of affirmation because of past trauma, but there's tiny ears over there and that's 15 years ago, right? But so it's something that I am learning to improve on, but the glimmer was speak words of healing over yourself because words have power. And I'm like, that's so important. But also I can't help but wonder about the sights, sounds, and smells in that setting themselves being triggering.
Yeah. And think about how the baby feels,
Yeah.
I think that, I had my own feelings, but then I'm like, oh my goodness, you also have this feeling like, I'm so sorry were removed from me too soon. You're like, oh my goodness, this is not where you're supposed to be. You're supposed to be back in my womb, in my tummy,
Yeah.
and then you have to leave your baby there. I don't know. And then I would watch my baby cry, on the video camera, and I would call, be like, hey, can you give her a pacifier? And, you also have anxiety. I had anxiety, I guess I should say that, about like having to call and do that. Because you're like, I don't want to be the mom that's like, that's annoying them.
But that's attunement and attachment 101. That's a baby cries. We have to be attuned to develop healthy relationships and attachment. You give them, we call them a binky. I had a lady call it a patu one time. So binky pacifier or whatever. Different words for different people, but attunement and attachment sets the foundation for so much learning later on. And that starts in the NICU when they decide to pop out a little bit too early.
Well, that, whole relationship is disrupted. It's not like normal.
Yeah. Yes.
Yeah. And, having that compassion for people. It's a hard space because you've got to know your clinical knowledge. You have to know how to navigate people from the professional aspect. You have to know and remember how to bring compassion at the bedside and be present in the moment while you're also navigating your own life situations. I think that's like any kind of therapy setting. It could be, the story's the same. There's just a lot on us as therapists. There's a lot. I don't want to say pressure because I don't know if pressure is the right word. I think it depends on the day of what you're going through, but there's a lot for us to juggle because as much as we need to be trauma informed, like clinically, we also need to be doing that to ourselves.
Yes. And then breaking down the stigma that counseling is bad, right? Because that's something, counseling is valid. Going to speak to someone about what's going on in your world. I feel like, have you ever heard of a sin eater? A generational sin eater. It's a term that I grew up hearing when you change the sins of your forefathers and you stop it so that those traumas are not passed on to the next one. My family's Cherokee and Potawatomi and a whole lot of Irish. So that's a phrase I grew up hearing. We got thumbs up of approval from Bear in the background. But when you're, for us as a family, that means one of the sins that we're eating is that counseling is healthy. And so encouraging that for our student clinicians and our younger clinicians to start that out. Y'all, we've had Kayla Duncan on a couple times in the past to talk about counseling and safety for a therapist and for new students. Kayla's been gracious enough that she'll actually go and do in-services. She lives in Texas. Hell's Bell. She just moved back to South Carolina like a couple months ago, but she was in Texas. And she would tithe of her time and go and do lectures about self-care. And as she said, she is a beautiful, bold Black woman, and she was trying to change the tide for even um, uh, within her culture of mental health matters. And it's just, so y'all get counseling. Yes, counseling's great. Yes.
Yeah. Or make sure you have a really good friend. If that's not for you, make sure you have a good friend that you can talk to. And I think it's also hard to make time for that when you're in the grind.
Yes.
Mm-hmm.
Yes. Virtual counseling is working for Pac Dawson. And so grateful. Adagio House, if you're listening, we love you. It's a neurospicy clinic. They thrive on helping neurospicy families and neurospicy kids. They even have an autistic dating afternoon, which I think is just like adorable. So, yeah.
It's very unique too, you know. I've only heard that like on, so when I think of that, I think of the Netflix. I think it's on Netflix, the show.
Yeah, that's its favorite show. Okay. We have Christian. My husband has an autistic older brother, and he has a friend that is a girl that is not his girlfriend, and he's very clear about this. But she adores Uncle Matthew, and it's kind of watching them together, and I'm like, they could have their own episode.
I bet they could, and I would watch it and love it.
My mother-in-law would kill me dead. I'll never say that again.
Oh my
goodness. But okay. If anybody is listening, and I should have told you about this beforehand, but if anybody is listening and they have a little bit of extra love money lying around this month, is there an organization or a entity that you would recommend that they donate to?
That's a good question.
It could be more than one. And it doesn't even have to be professionally related. We've supported the Bob Barker's groups. SPCA. Yeah.
I just thought when I was in the NICU, Carter's Cause sent me a care package, and they sent care packages to NICU families. I'm trying to look them up on my phone.
I've never heard of
Carter's Cause. Let me see.
I hear a tiny human.
Oh, you hear that? I'm sorry.
No, don't.
I do have a tiny human. But anyways, I believe it's Carter's Cause, and it's not coming up on my phone, but maybe you can. Yeah, here we go. And unfortunately, I do remember this, but if you could look them up, it'd be helpful. I do remember that their efforts are paused. I believe their house caught on fire.
Yes.
But that, I would say that because they sent me a care package when I was in the NICU that was moving to me, and I was like, this is really nice. I think probably, I wish I kind of got it a little sooner in my journey. I remember that, and that could be maybe like a funding issue. I don't know. I love that you can hear all of that now in the background, my dog and everything. I do have a life, and isn't that funny? We are humans. As I well put out, I am professionally, I am a mom. I do have 2 golden retrievers, and I am married. So, and I have laundry that needs to get folded. I don't know. Do you have an organization you would recommend? I just say that from I like that there's organizations out there that are supporting NICU families.
Yes. Feeding Matters is always my go-to.
Sure.
Has been for years. Aside from that, a local food bank. Really truthfully, because I've had to refer families a lot locally to our local food bank. And that was something that if you had told Michelle 20 years ago as a graduate student, I would need to know where my local food banks are, where how to help families get information on power subsidies, rent support, domestic abuse shelter victims. And I would need to know where to go like that because life happens.
And that makes
Yeah.
me think I'm doing a 9-month leadership program through my county, and I'm
Awesome.
learning all about all of this in my county.
Yeah.
I would have
Yeah.
not have known if I
Yes.
didn't go through that. So try to get that's something I want to get better at, is getting more connected locally rather than nationally and on a state level.
Yeah.
I need to understand my community better, and I think that's probably the same for all of us. So that's how I'm learning about what's going on in my community, is I'm set aside time for 9 months to learn all about it.
That's bloody brilliant.
It's through the Chamber of Commerce. So I don't know, something to look into.
Yeah. I think if I say yes to one more thing, my husband might have a mental moment.
I know. I think that's relatable.
I'm going to put my helium hand down, but it's actually really freaking cool. Yeah.
Maybe next year.
2026, 2025 has been eventful thus far, but yeah.
I'm about to say it's already full. I hope not.
We survived January. Bloody hell, that was a year in and of itself. So
it really was.
Yes. But dear friend, thank you. Thank you for being
so
you, for shining your light, for sharing your story. Go love that baby girl big. Folks, wait, what is your Instagram handle?
It's at the Casey Lewis, and I just started. I'm going to be offering courses and mentorship through Casey for Babies. And so I'm really excited. Britt Patos and I have a course coming out in March. I don't know when this is going to air, but it will be available throughout the year. So if you don't know Britt Patos, I hope you look her up. She is a well-respected family nurse practitioner and researcher, and does all the research on nipple flow rates.
Yep. As soon as you say her name, all I can see is a stack of bottle nipples. That's how I associate her in my head. It's but happy bottle nipples, smiley faces, not the ones that we say no, don't use.
Right.
Yes. Awesome. Thank you. Thank you for being you. Hang on one second, hon.